Good morning, everyone. At the outset, would like to thank Dr. Abid and the organizing team for giving this opportunity and greetings from the India. I've changed the topic a little bit after discussing with the Dr. Abid. The topic is pancreatic pain, precision intervention for nerves and ducts, two pathway and one goal. Rather than EUS, I kept it endoscopic solution for chronic pancreatic pain. So some problems are just too complicated for the rational logical solutions. They allow insights, not the answers. Why the chronic pancreatitis pain is difficult to manage? Because as an endoscopist, we always think of putting the stent in a patient who has a chronic pancreatitis, but that doesn't work many of the time. Because the etiology is uncertain, there is very poor understanding about the cause of pain because pain in chronic pancreatitis is multifactorial, difficult patients, opioid abuse, continuously taking smoking, lack of validated assessment tools and scoring system for pain, and bias of a treating physician when patient goes to surgeon. Surgeon says he can do the best job. When patient goes to gastroenterologist, he try to do endoscopy. So I think there is always be a bias for this. Before going for pain management, it is very important for a physician to understand the chronic pancreatic pain is a complex pathophysiology. It has a wiring problem, both at the spinal cord level as well as at the central level, that is a neuroplasty. It could be a plumbing problem in the form of pancreatic stones, pancreatic strictures, associated gastric outlet obstruction, biliary obstruction, or patient might have a tissue injury, cellular metabolic stress, and these patients, because of the chronic pain, has a psychiatric illness also. So it is very important for management of pancreatic pain should always be multidisciplinary. What are the indication of intervention? That's very important. And the intractable pain is the only indication. On imaging, if you find a patient has a fluid collection, or you see a dilated duct with the stone, or you find a pancreatic stricture, but if the patient is not having pain, it is better not to treat these patients. And pain could be because of chronic pancreatitis or could be because of pancreatic malignancy, and the pain management differ in both. But as an endoscopist, we can tackle the ductal obstruction either due to stone or the stricture, or pseudocyst or the biliary obstruction. So as I said, the pain management is a multidisciplinary team management. Rather than when patient comes to us and we start treating, take the opinion of your surgical colleague, endoscopist, talk to the psychiatrist, treat patient medically, and opt for the best management strategy. Who are the patient who is the best for endoscopy? A short duration of disease, not a very severe or long duration of pain, absence of opioid intake, absence or cessation of smoking. The predominant disease should be in the head. That's very important, either a stricture or the stones. An absence of the mass lesion. If the patient has a mass, then it is preferable to do the head coring and complete resolution of the stone and stricture after the endotherapy. These are the patients who are the best candidate for endoscopy. So let's discuss about the pancreatic stricture management seen in around 20 to 50% of the patient. And stent ideal for, as I said, the burden of the disease in the head or the proximal body, a distal dilatation more than 6 millimeter. It is always better to exclude the malignancy, dilate the stricture with the bougies or balloon or Soendra retriever. And if the patient has a multiple stricture or the strictures are in the tail of the pancreas, it is better to subject these patients for the surgery if they are symptomatic. So conventionally, most of the endoscopies, what we have seen that they put a single plastic stent that shows an improvement in around 80 to 90% of the patients. It can be started with the 5 French, 7 French, and 10 French. It may be on-demand or prophylactic pancreatic stenting every 3 months, but the recurrence of stricture is seen in roughly around 40% of these patients. So putting a multiple plastic stent to remodel the structure, I think that is a better strategy, because what happened, you put a 10 French stent, you see still the stricture is there, and patient keep on doing on endoscopy. It is better to put the multiple plastic stent, and that shows a resolution of the stricture in more than 90% of the patient, and patient remain pain-free in more than 80% of these patients. While putting the stent, it is important, if you are putting multiple plastic stent, the first stent should be pigtail stent. If this is a straight stent, there is a chances that it can migrate in across the stricture and it is difficult to remove. People has also talked about the covered metal stent or the bumpy stent, but the problem is possibility of a de novo stricture formation is there. So I think it's still preferable to use the plastic stent. Now, how do you see that your endotherapy is successful? That is, after removing the stent, if there is an adequate contrast medium outflow into the duodenum when you inject the contrast into the pancreatic duct, or an easy passage of the 6 French catheter into the pancreatic duct, that will be your end of the treatment. But if the patient has a symptomatic dominant stricture that persists or relapses after 1 year of the single stent placement, then these patients are called as refractive strictures, and they may require a multiple plastic stent, or they may be the candidate for surgery. Now, pancreatic stones, as I said, stone burden in the head of the pancreas, it is better. They show the good response to the treatment. If the stone is more than 5 millimeter, it is better to do the ESWL, because ERCP alone, it is difficult, because pancreatic stones are different from the bile duct stones. And if the stone is less than 5 millimeter, you can do the ERCP. And the ductal clearance can be achieved in more than 90% of these patients. What is important is a proper selection of cases to be taken for ESWL. That is the key of success. Because if you look at here, the 3 diagram, first on the left, the disease burden is in the head of the pancreas. These are the best candidate for ESWL. The middle one, where the stones are in the mid body, you can take, and if the disease burden is in the entire pancreas, it is better not to do ESWL, it is better not to do the ERCP. If the patient is symptomatic, better to send the patient for surgical interventions. So what are the factors which predict the success of ESWL? This is very common. We of late getting a call that the patient has done the ESWL, but the stones are still there. So what is important is you should know the stone size and the density, a presence of strictures, duration of disease, use of narcotic, and how many shock wave has been given. At least a 5,000 shock wave should be given on the stone. Most of the people use the urology ESWL machine, and the person should be dedicated to that. Otherwise, the number of shock wave given to the stones are less, and these stones are not braked. So it is very important, a dedicated person should for ESWL. So operator experience is very important, the type of lithotripsy is important, and epidural anesthesia is must, I think that is important. So ESWL selection of cases, the size of the stone, operator, machine, number of shock wave is very important factor. So if you look at on the left side, there's a large stone burden disease on the head of the pancreas. After the 2 sessions of ESWL, there's a complete stone burden has gone, and either these patients may not require, because the stone get pulverized and they come off its own. But if the patient is still symptomatic, you can do the sphincterotomy and you can remove these stones. So if you look at this systemic meta-analysis and systemic review, the ESWL in chronic pancreatitis management, the complete ductal clearance is seen in roughly around 70% of the patients. And stone clearance and absence of pain at 2 years was a predictor of long-term pain resolution. This is the study from the India from AIG, an experience of 5,000 patients, a dedicated technician, dedicated machine, proper selection of cases, and complete clearance of the stone in the chronic pancreatitis seen in 72% of the patient, partial clearance in 17 and 10% of the patient, they are unsuccessful. If lithotripsy is not available, definitely you can do the pancreatoscopy, but it requires an experience. In this review and meta-analysis, the complete stone clearance was seen in 81% of the patients. But what is more important while doing the pancreatoscopy and doing the EHL, the stone should be in the neck or in the body of the pancreas. If they are in the head, it is difficult to maintain the position of the cholangioscope. But yes, in a selected, if the stone is single, situated in the neck or in the body, and if you don't have an ESWL facility, if the duct is dilated, definitely a pancreatoscopy can handle these stones. If you have done the ESWL, or if the stones are radiolucent or they are less than 5 millimeter, it is better to do the sphincteroplasty, that is, pancreatic sphincter can be dilated with the hurricane balloon up to 8 to 10 millimeter. It is like a biliary sphincteroplasty when there is a stone which is bigger. Similarly, you can do a pancreatic sphincteroplasty and you can remove the stone which is less than 5 millimeter, because it is sometimes difficult to remove with the balloon or with the basket. So pancreatic sphincteroplasty is also a good option. Now, very important message which I want to tell you. As I said, there is an always be a treating bias. So if you look, 25% of the patient of chronic pancreatitis, there is a possibility these patients should be directly subjected to surgery. 25% of the patients are good candidate for endotherapy. 25% of the patient can be taken decision after multidisciplinary team discussion. And 25% of the patient, there is a small duct disease, atrophic pancreatitis, central sensitization of pain. I think these patients difficult to answer and they should not be subjected to the surgical or endotherapy. It is better to treat with the multidisciplinary team. If patient has a head mass, patient has a suspicion of malignancy, large stone disease in entire pancreatic duct, or patient has an associated stricture, it is better to subject these patients for surgery. The last part of my talk is the pain management, that is a wiring, dealing with the nerves. So this is the celiac plexus neurolysis. Neurolysis means you are ablating the neuron, and the celiac plexus block, that means you are stunning the celiac ganglia. The neurolysis is done in the patient who has a malignancy, and the block can be done in a patient of chronic pancreatitis, that is a benign disease. So neurolysis is an ablation for the malignancy. Block can be done for the benign disease, chronic pancreatitis, who are not responding. This can be done centrally, or this can be done inside the ganglia. If you look at this video, I will again play. So this is the hypoechoic aorta in the longitudinal view. Just below the G junction, you see the origin of the celiac trunk. If you inject at this point, that is called a central or the unilateral injection. You can inject 0.25% bupivacaine followed by 20 to 30 ml of absolute alcohol. You put a Doppler. The advantage over the percutaneous or radiological method, the complications are less. So you can inject at the origin of the celiac trunk. You can inject into the ganglia. Ganglia can be seen roughly in around 70% of the patients. That is from the adrenal. If you do an anti-clockwise, so between the aorta and the left adrenal, you can see the small hypoechoic grape-like structure. These are the ganglia. Or you can do the bilateral, meaning that you focus the celiac trunk, rotate clockwise, inject parallel to the celiac trunk, then rotate anti-clockwise parallel to the celiac trunk. That is a bilateral injection. So the technique, as I said, it can be done bilateral on the both side of celiac trunk. It could be at the origin, that is central, broad, that is at the level of SMA origin, and direct celiac ganglion block can be done. So if you look at the literature between unilateral and bilateral, I think there's a lot of diversity, but this is an RCT which found there is no difference in the pain relief. Either you do unilateral or bilateral. Celiac plexus neurolysis pain relief, both in the malignant and the benign disease, better pain control in the malignant disease in comparison to benign, both meta-analysis by Pooley et al. And Kaufman et al. Comparison of celiac ganglion versus celiac plexus. Again, there is no difference. Earlier study shows that in ganglion you require to inject less amount of alcohol and it shows a better pain relief, but the later study shows there is no significant difference. So celiac plexus block again for the benign disease, bilateral injection superior to unilateral. The data is too much different, but definitely if patient has responded to first celiac plexus block, the chances that he is going to respond with the repeated injections. This is the meta-analysis in the benign disease celiac plexus block, and you see 4-week 52%, 8-week 57%, and at 26 only 3% of the patients. So in my opinion, personal opinion, celiac plexus block in the benign chronic pancreatitis has not great role, but definitely in the malignant disease, definitely it is effective. It reduces the need of opioid analgesia, it reduces the dependency, it reduces the side effect of drug. I think in the malignant cases, a celiac plexus neurolysis is advisable. So to summarize and to say, it is important instead of being interested in what is new, because people talk about EUS guided celiac plexus block in chronic pancreatitis. I think that's not important. We ought to be interested in what is true, what is good for the patient, what is right for the patient, how these patients should be taken care. I think that is important. So I think for the management, careful selection of the patient is very important. For endotherapy, the disease confined to the head of the pancreas, absence of mass, smoking and alcohol abstinence, ESWL for radio-opaque stones more than 5 millimeter, ERCP for the stricture and the stone less than 5 millimeter, longer duration of stenting for the stricture. The studies has done for 7 months or 1 year. That is the reason the people are going to talk about the NEJM article with the JAMA, where the surgery is superior. I think if you read carefully, the selection of patient is more important to give the better result as good as surgery. Plastic and the SEMS are equally efficacious. My personal belief, plastic stents are better for the chronic pancreatitis. EUSCP and medical refractory pain for pancreatic malignancy is effective. Chronic pancreatitis, in my personal opinion, I don't use it, but if anybody is using, I will happy to share. Thank you for the patience here.
Thank you so much for that amazing talk.